Welcome, everyone. I'm Noah Reed, Vice President of Sales and Marketing for the Dutch Test. Thank you all for joining us for this Dutch webinar featuring our very own clinical educator, Dr. Allison Smith. Today, Dr. Smith will be presenting on sleep and cortisol. Insomnia affects approximately 30% of American adults. When patients present with sleep complaints, it's a common practice in functional medicine to test free cortisol to ascertain the degree of impact poor sleep has on the stress system. Free cortisol measurements only reflect the cortisol in circulation and do not speak to a patient's total cortisol production. Did you know there are other cortisol markers that can take the assessment one step further? This webinar will help providers focus on elements of adrenal and HPA axis function beyond free cortisol's diurnal rhythm to ultimately shine a brighter light on the root cause of sleep disruption. Before we begin, I want to remind you that class is in session in a special edition of the Dutch podcast. Our summer school series is available to stream now wherever you get your podcasts. Each week in summer school, our Chief Medical Officer, Dr. Jacqueline Smeaton, will sit down with one of our wonderful clinical educators to talk about hormones and review Dutch case studies. Each episode focuses on different topics in the world of hormone health and functional medicine. And in line with today's webinar, episodes 2 and 3, which are available now, are all about cortisol and the diurnal pattern. Be sure to give them a listen after the webinar. These episodes are full of important information that will help you make the most of your patient's cortisol results. And as always, we would like to extend an invitation to all of you that are joining us for the first time to become a provider with Dutch. There are many perks to being a registered Dutch provider. Dutch providers have access to exclusive educational resources like the Mastering Functional Hormone Testing course and the Dutch Interpretive Guide. Plus, one-on-one consultations with Dutch clinical educators like Dr. Smith and opportunities to learn alongside other new Dutch providers in group mentorship sessions. You can find links to all of these resources in the Dutch provider portal. Make sure you click on the link in the chat if you want to become a provider today. Now let me introduce today's speaker. Allison Smith, ND, completed her education at the National University of Natural Medicine in Portland, Oregon, and has worked in private practice focusing on primary care, women's health, and dermatologic laser therapy. That's my favorite word to say. Over the last 10 years, she has consulted with providers on thousands of cases in the context of hormone testing and brought awareness of testing to providers in clinical practice through consulting, webinars, case presentations, and articles. She now leads an esteemed lineup of clinical educators at Precision Analytical, home of the Dutch Test. Thank you for spending some time with us today, Dr. Smith. We're ready when you are.
Absolutely. Thank you for having me. I'm so excited to be here. As Noah said, this is me, Allison Smith, lead clinical educator here at Dutch, and I've been in the lab space for 10 years. I've sure seen a lot of lab tests in that time, and pretty much every single body fluid that you can test hormones in. So that is pretty much about me. I'm super excited to share with you everything you need to know about how to use dynamic cortisol lab tests to help identify the root cause of sleep disturbances. That's what today is. So before we get started, the case studies and the slides that follow are really all just going to be provided as informational resources and should not be taken as medical advice. As good as some of this stuff may sound, always kind of run things through your doctor, right? As Noah always says, I'm a doctor, but I'm not your doctor. And, so let's look at all of this as kind of an educational experience. So today's agenda, I'm going to talk about the assessment of the diurnal rhythm of free cortisol, which I think, a lot of us have experience with, but we'll introduce the cortisone diurnal rhythm and some brand new research on the cortisone awakening response. It's something that we've been thinking about for a long time here at Dutch, but just starting to see the very first research study kind of establishing that stake in the sand that you may be able to assess an EAR or an ear. And we also want to cover a good amount of information on the metabolites of cortisol. And we've covered this quite a bit in the past, but it's probably the number one question we get from providers when we're doing consults about lab tests is that one little piece of information that tissue metabolites of cortisol still gets people stumped. So I want to spend a good amount of time on that and how it plays into sleep. We'll also cover some basics of sleep cycle along with hormone influences and weave in some of the nutritional and lifestyle interventions that you can implement. Um, and if you've never seen a Dutch test before, or this is your first foray into functional lab testing, this webinar may feel a little bit of a stretch maybe. But if you feel overwhelmed at any point during the talk, don't worry. If you're a provider, we have a 4-module masterclass available to you. If you're a patient, we have lots more foundational webinar content under Education tab and past webinars. Dr. Carrie Jones has several on cortisol that are great for getting started. In the meantime, I will try to make this fun and interesting, and I'm glad that you're here. So let's start with some stats. According to the big brains, following population statistics, about 3 in 4, so more than 30% really, 3 in 4 in 10 report symptoms of insomnia during any medical visit over the course of a year. And that's a lot of folks. For some recent data suggesting that the use of prescription medications for sleep has actually decreased in the overall population. And in the 80 plus population, steep decline, 86%. And that's from 2013 to 2018. And, you know, COVID has happened since then. So we may be on a little bit of a different trajectory at this point. That remains to be seen. But either way, for me, this kind of fills in why there seems to be such an influx of patients entering functional medicine practices that are essentially looking for medically monitored, natural and lifestyle support for restoring sleep, right? So we want to fill this healthcare gap if we can. So getting deep and restful, appropriate sleep for you on a regular basis is foundational to good health. We know this. Much of the research implies that you need to experience 4 to 6 cycles of non-REM and REM sleep each night. And here on the chart, right here, N1 through 3, N just means non-REM and REM is REM, right? Rapid eye movement. So N3 is the deepest sleep, is sometimes called slow wave sleep or delta sleep. You might hear it referred to. N3 really is where the magic happens for immune activity and memory consolidation, and for some of the effects of sleep on cognitive function to occur. So you can imagine, if your stress or cortisol is really high during that phase of sleep, very often you can start to have problems fighting off infections or feeling mentally acute in the mornings. So there's actually an intricate balance of cortisol activity during the night with other hormones that all work together to promote the progression through the sleep cycles that keep them continuous and restful. So some of the hormones and cytokines that influence our sleep phases are kind of surprising, like interleukin 6, right? Interleukin 6 keeps us asleep at night. Yeah, it's got to be within the normal range. If it's too low, it can affect our ability to reach, deep sleep and REM states. And, if it's too high, it can lend itself to sleep fragmentation. So, there are a lot of these factors that we want to keep perfectly within normal ranges if we can. Leptin and histamine. So it's some unexpected things that we might think, gosh, how does that play in? But all of these hormones can have an indirect effect on cortisol levels during the day and during the night. And these effects, whether they happen in the day or night, can impact our sleep architecture and how we feel during the day. So here's a little schematic I put together kind of for myself so that I could summarize how we cycle through the sleep phases and the types of things that we need to consider. So you'll notice a couple things here. First thing is that N3 deep sleep is the longest per cycle in the first half of the night, right? That's when we get our deepest sleep. And after that, the N2 phase and the REM phases, they start to increase in duration each sleep cycle of the night. So much so that the REM sleep phase increases from about 10 minutes here in the first cycle of the night, all the way up to an hour before you wake up, open your eyes for the day. So you might also notice that increase in REM corresponds with like a drop in leptin, right? So leptin is actually high when we come into the night, first half of the night, and it kind of directly opposes insulin and some of our other diurnal factors. And then by the end of the night, it should be nice and low. So if there are problems with our sleep architecture and some of these hormone levels, it can put us more at risk for obesity and misalignment of that leptin diurnal rhythm. So it's quite a dynamic interplay that relies on some autonomic inputs, parasympathetic and sympathetic activity, but also neuroendocrine inputs, melatonin, GABA, glycine, acetylcholine. Some of that stuff we can modify even through supplementation. Excuse me. If cortisol is high or low at night, it's difficult to transition through the phases of sleep seamlessly, right? N1 to N2 to N3 to REM, N1, N2, N3, then REM, N1, N2, right? We need cortisol for all those little transition points. So with high cortisol, patients seem to kind of get stuck in light sleep. And when they do make it into REM, it's short but fitful with more active movements, and it's hard to wake up rested, and fatigue is a common symptom during the day. With low cortisol at night, like in Addison's patients, well, and it's actually a cohort that's not very well studied, surprisingly, but there was one study worth poking around in down there at the bottom, if you're interested, that was looking at sleep parameters in patients with essentially zero endogenous cortisol at baseline. And then they used a glucocorticoid replacement or a placebo. And they found that low cortisol made it hard to progress from N3 sleep, right, that deep sleep phase, into REM, and it lengthened it out considerably. And they found that hydrocortisone replacement restored the proper N3 deep sleep length and depth, essentially, and it increased the REM time as well. So both high and low cortisol can have a negative influence on the sleep cycle. So low isn't necessarily better, I guess is what I'm saying. With your high cortisol patients with sleep problems, normalizing cortisols at night would be expected to have a big impact, really, on the entire sleep cycle. Just kind of giving you an idea of where that will act. Somebody has high cortisol, it's going to mess with everything. You can't transition through the phases. It's going to help really all of these phases to improve. With your low cortisol patients with sleep problems, normalizing cortisol levels mainly going to work here at the end of the sleep cycle, really, with your N3 sleep, helping it to transition into REM and increase it through the night, right? So why do we use cortisol to assess sleep? I think for some of us, it's obvious because cortisol is a unique identifier of a person's circadian rhythm. Cortisol does rise in the morning. It's the signal that turns on our daytime gene expression cycles in the organs that are outside the brain. They're called the peripheral clocks. And some of you may know that I love this slide because I put it in all of my slideshows. I feel like it reminds me of the clock genes in the pancreas and the liver and the GI and the gonads and there's a different set in each tissue. How does your pancreas know that it's daytime, right? It's dark in there. So there's a daytime relay of gene expression to set in every single tissue every single morning when we get up. And it's that coordinated event between the autonomic nervous system and light stimulation. And born out of that coordinated set of events, cortisol rise is the messenger to the rest of the body. Right? Cortisol is why the pancreas knows it's daytime. Free cortisol diurnal rhythms are pretty simple to collect at home, which makes them attractive for helping to figure out what somebody's circadian rhythm is, right? It gives us an idea of somebody's individual circadian rhythm. And it has a diurnal rhythm in saliva and in urine, so you can assess it in multiple body fluids. Today, we're going to focus on salivary free cortisol, so we can incorporate the cortisol awakening response, which can only be revealed by saliva. That's important to know. So the point of testing free cortisol throughout the day and measuring the cortisol awakening response in particular is to teach us about a person's individual circadian activity. Sometimes it's off, but also to add in that information about a person's ability to kind of prime their brain and body to respond properly to stress ahead, in the day ahead. Just challenges. I kind of think about it as like warming up the copy machine when you first get into the office in the morning, so you don't have to wait 20 minutes for it to warm up. If you want to make a copy at noon, like it's already done. So that's kind of what the body is doing first thing in the morning. It's that prime. So this is what a cortisol diurnal pattern is supposed to look like first thing in the morning, along with the cortisol awakening response. This is the normal range here. This is the upper end of the range and the bottom end of the range. The blue zone is where we want people to be. You'll notice that the waking cortisol is higher than the nighttime cortisol. That's good, right? So we want to be high in cortisol in the morning. We want to be low in cortisol at night. That's the gist, right? Circadian rhythm for this person is diurnal. They're up during the day and they're down at night. And then we have the awakening response here, where we have the rise of cortisol. Oops, I have pictures. Day, night. And then here is the cortisol awakening response. There's that rise of cortisol in the first 30 minutes of waking, and then the return of cortisol almost to baseline waking levels after that initial rise. So that tells us that the brain is ready. But cortisol has other roles in the body too, besides being just a circadian messenger. And I think the fact that cortisol does come up in response to stresses can muddy our idea of what the circadian rhythm is if there are stressors affecting cortisol's diurnal rhythm, right? And this can make it tricky to decipher the circadian rhythm of free cortisol when it's the same time as stressors being on board, right? Blood sugar dysregulation or inflammation, or you're at the emergency room with your son, or you lost your dog, and all kinds of normal stressors can increase your cortisol for perfectly good reasons. And so we wouldn't want to, say this person has a circadian rhythm problem, right? Because cortisol is our big responder to real-time stressors, really in just about every tissue in the body. Cortisol is a little, like a lot of our hormones, a little lipophilic hormone that can flit into a cell and interact with its own glucocorticoid receptors in the cytosol. And then it's transported to the DNA to upregulate genes that really help tissues to adjust to changing or stressful external forces. Just upregulates that gene transcription to handle whatever problem needs handling in that tissue at that time. So if there's one thing that you take away from our conversation today, it's that your cortisol levels themselves aren't the end of the story. Cortisol is really, it's a helper. It's a helper that makes stress signals into tissue actionable commands. Essentially. But its effects may be wonderful and needed in one tissue, and thank goodness for it. But when it's high for too long, there can be collateral in other tissues, and maybe not appreciating cortisol's actions there. For example, cortisol could be doing a great job controlling inflammation in a joint, but it could be making your hair fall out or making your bones brittle. So here's a chart detailing many of the tissue actions that cortisol implements, which are played out according to the circadian clock-driven gene expression, but also can be triggered at off times by stress, sympathetic nervous system activation. So you can imagine, you don't want white fat redistribution to the midsection all the time. We don't want downregulation of the immune system all the time. And we don't want, insulin resistance all the time. Only at key times, diurnal times, or times of acute stress. And most importantly, we want to ensure that return of a normal cortisol diurnal rhythm once that stressor is resolved for good, right? We want to rise and then return. So let's recall acute stress physiology with a spin to incorporate what happens to sleep. So right up top here, stressors on the body and in the body are converted into chemical messengers. We have our cytokines and chemokines crossing the blood-brain barrier, conferring that stress to the brain. When the hypothalamus and the hippocampus perceive that stress, then the hypothalamus produces signals to the adrenals to make cortisol, and the brain changes the sleep architecture to favor deep sleep. So you get more immune cell DNA expression, more immune cells out there, infection is cleared, voila, we're done, and cortisol returns to normal. But we have to take into consideration that sometimes the stressor is not totally cleared, and inflammation might be persistent despite best efforts. And when it becomes a long-term stress on the body and the brain, we do see hippocampal volume decrease, right, over time, which affects sleep architecture. We also experience what's called glucocorticoid resistance, which leads to HPA axis dysfunction and an attenuated cortisol response over time, right? So cortisol's not able to respond over time, and we get this sort of runaway train systemic inflammation, longer-term sleep fragmentation, we lose our diurnal rhythm, sleep problems. So this is what glucocorticoid resistance looks like on a diurnal cortisol in a car, right? We don't see a rise. We don't see a very big difference between morning and night. There's not much of an area under the curve, right? So this flatline curve, in this case, actually is someone dealing with chronic pain. So those stress signals don't stop begging the hypothalamus for cortisol. And without that reprieve, other relays that respond to pro-inflammatory cytokines with, whatever stress activated protein kinases or whatever, they start to block and downregulate glucocorticoid receptors in the brain. And at the target tissue level, it also downregulates expression of the GR alpha sort of active receptors, and it upregulates their replacements, the GR betas, which severely limits their ability to interact with the DNA and have a glucocorticoid action. So this is the place we don't want our patients to end up, right? We want to avoid this, but if they do get there, this is a reversible state with the right approach. Stress, when it's chronic, begins to affect sleep architecture and hippocampal volume. Lower hippocampal volume alters the HPA axis ability to adapt to stress, and it also decreases our ability to get deep sleep. So you kind of see how these are all related. And not getting restful sleep sort of feeds back into the chronic stress state by way of that maladapted HPA axis activity. So it's all kind of bidirectional, multi-directional, and affects each other back and forth. Oops, sorry. In fact, hippocampal volume correlates strongly with our ability to be resilient to stress. So higher volume, more resilient, lower volume, less resilient. And important to our conversation today, hippocampal volume and function governs our cortisol response to waking. So it helps our brains come into consciousness, and it makes us feel ready to face the day when we wake up. So incorporating the CAR into your cortisol testing can give you that additional information about hippocampal damage. So let's review some of the conditions associated with chronic sleep loss. There are many. Some of them are metabolic, affecting our body composition. Others are inflammatory or mental emotional. And maybe all stress-related conditions are associated with chronic sleep loss. So, if you have a patient who is suffering from insomnia or chronic short sleep or even long sleep greater than 9 hours, I just thought of this. I should have included a slide, but there was a Medscape alert that came through a new study that was looking at esophageal cancer being related to short sleep less than 5 hours or long sleep greater than 9 hours and even daytime napping. So look, we're not the only people thinking about how circadian health plays into risk of disease, even cancers, and influences cancer outcomes. And that in no way means that if you have circadian dysfunction, you're going to get cancer. That is not at all what I'm saying. I'm sorry if that is a takeaway, but I think, there is a relationship between the disease state and disrupted sleep. And it is through that circadian dysfunction that we can get after these things before dysfunction begins to occur. All right. How do we use sleep to assess, or cortisol to assess sleep? This is really what we're all here for. On the Dutch test, we've got 3 important measures. We've got the diurnal rhythm, we have the CAR, and the tissue metabolites, which I couldn't say at the beginning of this talk. Tissue metabolism of cortisol. We're looking at tetrahydrocortisol and tetrahydrocortisone levels when they're made in the liver and adipose tissue and enter the urine. We can kind of look through that cortisol trash, and we can see what's going on with systemic inflammation, what our metabolism is doing, and we can really figure out where some of these abnormalities are coming from so that we can throw more than just adaptogens at our patients with circadian rhythm dysfunction. In functional medicine, we often use the diurnal cortisol pattern as a general health predictor. So don't be surprised if you go into your doctor's office and they run a diurnal rhythm, even though you don't have sleep problems. It's not just sleep. It is routinely studied for its relationship with insomnia and sleep problems. But much of the medical literature on cortisol daily patterns all suggest abnormalities contribute to all-cause mortality, cardiovascular disease, obesity and toxic exposures, depression, type 2 diabetes, so many things. So that's really why we work so hard to assess and modulate HPA axis and the sympathetic nervous system when patients come in with chronic complaints in general, right? It's not just sleep. And there's starting to be more studies using the CAR to assess chronic versus acute insomnia, or chronic versus acute anything, really. For me, when I'm assessing the CAR, I kind of zoom out. I'm thinking generally about high CAR, acute, high sympathetic nervous system activity maybe, and low CAR, more chronic, low hippocampal volume, maybe long-term damage from stress in the past and in the present, or chronic issues, chronic insomnia in this case. All right, so remember, here's our proper diurnal cortisol curve with the normal CAR, which is calculated value, actually. So we've got waking and the waking plus 30. And this person increased, let's say, from 2.5 to 5 in the first 30 minutes, and that's a 100% rise, which falls into the normal range. So that's kind of how we do that, how we come to that conclusion. And about collecting the CAR, this is super important, and I wanted to include a slide in here because it's so important. If you're collecting saliva for testing the CAR, as soon as your eyes open in the morning, it is time to reach over to the nightstand and start collecting that first saliva sample. If you're waiting until after you go to the bathroom or have breakfast or whatever, you kind of run the risk of missing your actual CAR by starting the collection process after the CAR has already begun. So remember that. So just kind of be ready to get that done before you go. It takes about 30 seconds to collect one of those. The way the Dutch salivettes, just throw it in your mouth, kind of chew on it a little bit, and it's ready to go. Those who are waking frequently during the night, I do suggest collecting the first sample just before you get out of bed for the day, even though it kind of feels a little bit arbitrary, but that'll be your stake in the sand. We have three main abnormals that we're looking for when I'm assessing a CAR: the high, the low, and the prolonged. Here's some examples. So here's the high CAR. You can see this patient has severe anxiety, fatigue, and a history of difficulty falling asleep at night. So we can see immediately that the waking cortisol is on the low edge there, right? It's on the low edge. And there's an elevated or CAR of 250%. That's a lot, right? If we want to top out at 160 and they're at 250, that's a pretty significant CAR. And I would say it's even more evident in the free cortisone pattern here on the left. So that's just a huge effort first thing in the morning. And to me, this is a person that's like all stress response and nothing else, right? Low waking cortisol, lower afternoon. The most normal he is all day is at night before bed. So no wonder he has trouble falling asleep, right? This is the blunted CAR pattern, kind of speaks for itself. That rise from waking to waking plus 30 just doesn't exist. It's just a drop. And in this case, the pattern goes with the chronic insomnia and morning fatigue. Kind of what we expected. And then we have the prolonged stress response. I pulled this example as one of an elevated CAR, right? 214%, but it just keeps on going, right? That failure to return to resting. And this one goes with anxiety, fatigue, and sleep maintenance issues. So when you have a really touchy HPA axis, it can make it hard to kind of return back to that baseline resting state after a stressor is resolved. So really what the CAR tells us that the diurnal rhythm doesn't, the CAR is much more specific to brain adrenal communication and the volume of that stress response, whereas diurnal cortisol is much more of a clue to circadian activity. So really just kind of two different angles. Treatments that are geared towards the CAR, as you can imagine, are typically best applied very early in the morning upon waking, maybe even right when you would collect the first CAR sample, kind of have it on the nightstand, or light therapy first thing in the morning within the first 10 or 15 minutes of waking. To be able to apply that light therapy can be really powerful. So first thing in the morning or maybe at night before bed. So if you're using supports that are designed to modulate HPA axis activity and sympathetic nervous system, And parasympathetic balance may be best applied at night before bed, and then those very first morning supports first thing in the morning, right? Let's look at some different diurnal cortisol and CAR irregularities. Oh yeah, I have a quiz. Some of you guys have done this quiz before. It's not very hard. Let's recall what we're looking for. Which curve is more resilient? We're looking for waking being higher than night. We're looking for a nice rise from point A to point B, and we want it to return to normal from point B to point C. This one's much more resilient, right? It rises, returns. This one wakes up low. You could almost draw a straight line across the whole day for their diurnals. And then they have a really reactive CAR. So more resilient on the left. Number one. You're already getting it. I have lots of pictures, I guess. Okay. So before we jump into the patterns, this is a reminder to assess those middle of the night samples for patients who collect them and send them in. This is really valuable information. Remember, high cortisol production at night makes it hard for patients to transition through the phases of sleep, and they end up with little deep sleep and shorter REM stages. They wake up fatigued in the morning. So especially if cortisol is high in the first half of the night. So it matters somewhat when they collect their night sample. What I mean by that is if they wake up at 1 in the morning and take their saliva sample and their cortisol is 1.3, like this patient, it means more than if their cortisol was 1.3 a half an hour before they woke up for the day. Does that make sense? It should be coming up at the very end of the night. And so you wouldn't key off on that just before waking high like you would a middle of the night high earlier in the night. So here we go. We're going to rock through these. Take the flipped curve there on the left. So flipped curve is low waking, high night, and it's hard to get deep sleep early in the night when cortisol is high. So the CAR is huge, right? Trying to resolve this stress of the night. So this is definitely somebody who has a dysfunctional rhythm that may be playing into sleep problems. So the considerations I think of with that elevated and prolonged CAR are like sympathetic nervous system activity. This is maybe an acute insomnia or depression playing into these dysregulations. Which brings us to the dysglycemic pattern on the right. That could easily be called the chronic anything pattern, chronic insomnia or chronic sleep apnea. So high waking cortisol is very characteristic of sleep apnea, dysglycemia, and also chronic insomnia. And that blunted CAR is also characteristic of all three of those as well. So we really would have to look into, cortisol metabolites and other markers that we know about the patients to tease out what we think that is, right? Poor sleep quality can have a few different presentations depending on the drivers. For instance, it's not unusual to see high bedtime cortisol kind of coming up like this, in folks having trouble falling asleep and staying asleep. High waking cortisol in the top graph there. Remember, we talked about that with the dysglycemia, sleep apnea, chronic insomnia. So there can be many reasons we would see that high first thing in the morning. But that blunted CAR should really make you think about a chronic presentation, and of course the flat line curve we've alluded to signals HPA axis dysfunction and low hippocampal volume. So, not a lot of circadian variation there. I can't imagine this person's pancreas knows what time it is, right? Remember, cortisol itself isn't the problem we're looking for. High cortisol suggests a stressor is in play. So a prolonged CAR suggests additive forces beyond just the typical HPA driving cortisol production. So inflammation, infection, deficiency, something. Not just cortisol that makes somebody feel fatigued or anxious. It's whatever's driving that cortisol. In this case, a headache. This person had a headache between their afternoon and night samples around 6 p.m. And so you can see that, otherwise her rhythm would have just gone straight down probably, but she had a headache. And so we really need to circle back to the patient, figure out what's going on during the time when there's elevations. And this person was really sick, so she's like huge response first thing in the morning and just can't maintain it. So just interesting. And remember, even the flatline diurnal pattern can be quite reversible with the right approach. We're not going to go back through all this, but HPA axis dysfunction looks a lot like this. Here are some examples of therapeutic lifestyle and supplement considerations for diurnal cortisol issues. And you can tailor these or combine them to support sleep disturbances that are either perpetuated by or causing diurnal cortisol disturbances. And you'll notice that I have the adaptogens kind of broken down into their categories, characteristic of their top secondary mechanisms, if that makes sense. So many of them have been studied for increasing hippocampal volume too. So you have your little repairing hippocampus ones. But they're all adaptogens and they all work to normalize cortisol output. A note about napping. I didn't really know where else to put this about napping. Napping up here. Napping has been shown to be beneficial to interleukin-6 levels and cortisol levels after a night or two of sleep loss. However, there does seem to be a consensus that regular daytime napping over 90 minutes can be problematic for some people because it can shift the sleep phase and result in more nighttime and sleep problems in our folks who struggle with more chronic sleep loss. So that's something to think about. It can be helpful in some cohorts, but not great in others. So really individualize your plans, and it's not one size fits all. On the Dutch test, you'll notice we also report free cortisone at each of the same time points. So I want to spend just a little bit of time unpacking where cortisone fits in with the assessment and introduce some brand new research on the cortisone awakening response, or the EAR. Cortisol and cortisone are two sides of the same coin. Cortisone is simply the oxidized form of cortisol, and it's formed in the salivary gland, kidney, and colon. So our end body fluid producing tissues. And it can be regenerated back to cortisol in other tissues like the liver and the adipose tissue. So you can imagine the interconversion of cortisol and cortisone is highly regulated by the tissue that it's in and the circumstances. So the short of it is that we have a set of enzymes called 11-beta hydroxysteroid dehydrogenase, 11-beta HSD, that are dedicated to interconverting cortisol and cortisone in the liver, or in converting cortisol to cortisone in the kidney and salivary gland. And this is the one that's in the kidney, single arrowhead. This is the one in the liver and adipose, double-edged sword. The cortisone is formed from cortisol locally in the tissues, especially in the tissues that form our end body fluid. So remember, when we're looking at saliva, some of that cortisol that entered the salivary gland, some of it's going to convert off into cortisone. Same thing in the kidney and the renal tubule. Cortisol is getting taken up, right, by the glomerulus, and it's all getting filtered through. Some of that cortisol is going to convert off into cortisone. This is because cortisol can bind aldosterone receptors. You can see how similar their structures are. So these tissues must regulate cortisol-cortisone conversion really tightly to avoid big swings in blood volume and blood pressure and electrolyte balance, right? It makes sense. And that makes sense why your cortisol-cortisone balance in, the saliva and the urine can be really different from your cortisol-cortisone balance in the liver when we're looking at the metabolites of cortisol, right? Cortisone can also be formed from cortisol via 11-beta HSD1 in the liver and the adipose tissue. So, right, that's that double-edged arrow. And this all happens outside the watchful eye of the HPA axis. So where this becomes important is cortisone can be sort of absorbed up into liver tissue and adipose tissue, and it can turn back into cortisol. So extra adrenal cortisol synthesis occurs in the liver and the adipose tissue. And that's why the metabolites of cortisol can get huge in the urine, even when your free cortisol and free cortisone are really low, or even normal or low in the urine, right? Because those tissues that can make cortisol out of cortisone are doing that. So it's a sign of inflammation. So cortisone itself doesn't have a diurnal rhythm in the serum. The body makes sure it's constant in circulation. So cortisol converting locally in the salivary gland to cortisone gives cortisone its diurnal rhythm in saliva. And it's simply an additional marker of cortisol. That's really what it is. The see here, the diurnal cortisone pattern just kind of beautifully mirrors that of cortisol. Right? So patients with high 11 beta HSD2 activity in the kidney or the salivary glands may have low free cortisol and very normal or even high cortisone at each time point. So the important takeaway here is that you wouldn't treat this person for low cortisol. Right? This is not a low cortisol picture. Free cortisone is informing you that in fact there's normal cortisol in circulation and the diurnal pattern is correct essentially. Right? So why is this happening? I would say, check blood pressure meds. This enzyme can be upregulated in obesity, where the body's trying to hand more cortisone to adipose tissue, and it can lend itself to that adipose tissue dysfunction that we see sometimes. It's something we might see with sodium potassium imbalances and blood pressure and blood volume issues. Maybe even low blood pressure problems, or somebody who has like hypostatic or orthostatic hypotension, where cortisol is getting converted off into cortisone and can't assist in binding mineralocorticoid receptors. So we must look at cortisone as a surrogate marker for cortisol in these patients, but that imbalance could be actionable under some circumstances, right? Maybe a little licorice would be helpful here. Or if this is a product of somebody's diuretic medications, we might want to leave this alone because that's what's keeping their blood pressure down, right? Here's an example of hydrocortisone contamination where we see big, huge, high levels of cortisol. That's not their cortisol, that's hydrocortisone, which is bioidentical cortisol, by the way, that somebody has put onto their skin or used as a lip balm or whatever was on their fingers when they collected their sample. We're going to quantify that cortisol as theirs, and it's not very usable, actually. In this case, we have to look at the cortisone pattern to fill in that information. And in fact, the patient did disclose that they were using hydrocortisone cream on the day of collection. And there's some study that says, hey, you can use free cortisone as a nice biomarker for serum free cortisol. So we felt pretty confident telling people that they could use the cortisone awakening response probably, but that it was not established in the medical literature as yet. But there's a little bit of new research that I wanted to present today. And I haven't read the whole study, I admit. It's a brand new study, and it's pay for play. So I haven't been able to read through the whole thing, but I'm hoping the Anderson study here at the bottom spurs on some more further research exploring the use of the ear over the car for patients who have a high 11 beta HSD2 enzyme activity, like this person. Look at this person who doesn't have much of a car, right? 22%, that's pretty low. But if you look at their ear, 68% rise. That's perfect. So really, there may be situations where it's appropriate to use the ear over the car, and certainly hydrocortisone contamination right here, we would have to rely on the cortisone on the ear. So that's that. Exciting. So let's talk about cortisol metabolites, because the way the body metabolizes cortisol on its way through the liver and the adipose tissue gives us clues about acute and chronic stressors. So you see abnormalities in the cortisol curve, you want to figure out, well, what's driving those? The cortisol metabolites can be a really nice indicator to point to that. So tetrahydrocortisol and tetrahydrocortisone, the THF and THE metabolites, are the cortisol and cortisone metabolites formed in the liver and the adipose tissue that are inert downstream products of the breakdown of cortisol, right? Evidence of past presence or activity. And we find them in the urine, where they collect over the course of the day, and they tell us about total production of cortisol in the body and about cortisol's clearance rate when we compare them to the total free cortisol, right? So how much we're producing and how fast are we clearing it. One super handy thing about cortisol metabolites is how they naturally give you an idea of whether the body is acutely handling a stressor or if it's gathering up cortisone to deal with a chronic stress burden. So the predominance of cortisol over cortisone metabolites over here suggests suggest acute systemic stressors, right? And the predominance of cortisone over cortisol suggests chronic ones. And there are 4 patterns of cortisol that I'm going to touch on next. It's kind of, I made a little clever resource here. I don't know, hopefully you find it helpful. But hypermetabolic pattern, we're going to see a low free cortisol and a high metabolized cortisol burden. So that's how you would use this. Hypometabolic pattern would be high free cortisol and low metabolized cortisol, right? And low for hypocortisol. Anyway, I hope you find that helpful, especially when you're just getting started. High cortisol metabolites you'll often see in patients who are struggling with the disease of obesity, type 2 diabetes, inflammation, fatty liver, hypertension, a lot of the metabolic syndrome constellation, even sleep apnea. Right? And here are the top contributors to high liver metabolism of cortisol. Importantly, elevated metabolites of cortisol can exist while free cortisol is very low. So that's that hypermetabolic pattern we were talking about. So it's really important to look at metabolized cortisol when you see low free cortisol in circulation on the circadian rhythm or the absence of a cortisol awakening response in a person who otherwise you would expect to have high cortisol. It might be captured in the metabolites of cortisol. They may be a hypermetabolizer. So we're looking for inflammation, insulin resistance, chronic infections, high morning leptin levels, maybe those sorts of things. In fact, high metabolites of cortisol in the urine is almost synonymous with high 11-beta HSD1 activity in adipose tissue. So big adipose tissue contributor to those metabolites. And I don't know if you follow the research on the 11-beta HSD1, but elevated activity and high cortisol metabolites are associated with waist circumference, as far as an anthropomorphic marker that you can just test in your office, and with HOMA-IR, that you might have in somebody's just regular old serum labs. But you'll also see it in fatty liver and sometimes in sleep problems, especially sleep apnea. And medications geared towards inhibiting 11-beta HSD1 in studies act to restore blood sugar and improve body composition. So it's emerging as kind of a target. So you'll notice a lot of the factors that increase 11-beta HSD1 are modifiable and associated with high cortisol production to begin with. So naturally, we're kind of making that connection with cortisol. And there are, of course, some genetic and epigenetic factors too that can play a role. Here's an example of a hypermetabolic pattern. So this is a 28-year-old female with obese BMI. Notice that the low free cortisols here are correlating with a very high metabolized cortisol. So this kind of classic situation that should make you think of inflammation, insulin, or an immune etiology possibly, right? But chronic because she's got this pull towards the cortisone metabolites. That adipose tissue is really collecting a lot of cortisone. Here's another hypermetabolic pattern. I'm sorry, I actually don't remember if this one has a sleep complaint associated with it, but I pulled this one because the assessment was a little tricky. Here we see a pretty low overall free cortisol and free cortisone showing pretty much as well, right? A little wimpy, maybe a little higher in the afternoon. Just got this funny high night before bed. So high at the wrong times, low at the wrong times, but essentially a flatter area under the curve with low waking. And when we look, the car is 70%. So really, her HPA axis is functioning normally. That range for the car is 50 to 160%. Her car is 70%. So if her HPA axis is functioning normally, why is her circadian rhythm so weird? Well, this is why. Metabolites are not elevated, but they're on the high end of the normal range compared to that really low free cortisol and free cortisone showing. So that really just tells you that the liver and adipose tissue are pulling cortisol out of circulation as fast as they can. And why would they do that? If she's insulin resistant, she's going to need cortisol as a rescue. If she's inflamed, if she has an infection, those sorts of things. And all of those can lead to sleep disruption. So treat the cause, right? This is not somebody that you'd be treating for low cortisol. That's the takeaway. Treatment goals for the hypermetabolic pattern are to solve the tissue issue. Usually you can figure out what it is, assess for metabolic syndrome. Is the patient overweight? Is there a high waist-hip ratio? Do they have high inflammatory markers? Is there sleep apnea, prediabetes? You just kind of work down your list. Go after what's pulling cortisol out of circulation, solve that problem, break the pattern of chronic stress, and then diurnal rhythms can return. Your adaptogens start to work better. Metabolic functions can improve because inflammation really just takes the diurnal rhythm away. These are the patterns of findings we tend to see on a Dutch test. They're in the honeycomb and some of the tried and true anti-inflammatory supports in functional medicine. So this is the inflammation. I'm pulling in other markers from like the sex hormones and oats sections as well, just so that you can kind of put together some of that information along with your, aberrant free cortisol patterns. Here's a schematic of the collection of markers we often see in combination, highly suggesting oxidative stress. So you could make the argument probably for adding a high VMA and a low melatonin here too, but yeah, high metabolized cortisol is there, and there's some overlap with inflammation markers. So pyroglutamate and 8-OH-DG are probably a little more indicative of oxidative stress than inflammation, but a lot of the treatments overlap as well. So when you're treating one, you're usually treating the other, luckily. And that may even be true for insulin resistance. Here's what I put together for insulin resistance on a Dutch test, right? And type 2 diabetes is associated with low hippocampal volume and HPA axis dysfunction and sleep problems. So we really want to learn to spot these patterns. And they might have several of these things going on that might send you more towards the insulin resistance camp or the oxidative stress camp. But the whole point is to identify early signs of imbalance so we can gently reset the course through lifestyle interventions and prevent diabetes and cardiovascular disease and a lifetime of being a ball and chain to our medications. So that was high metabolized cortisol, right? The insulin, inflammation, immune, apnea, that was high metabolized cortisol. So this is going to be low metabolized cortisol, low metabolites. It can indicate low production of cortisol overall, and or it can indicate low basal metabolic rate. Right? So you could have a very normal circadian rhythm, but really low metabolites of cortisol. Maybe you have low metabolism. And we see that sometimes with hypothyroid or anemia. Really, all of these can play into that. Low caloric intake or even anorexia. You might have really high free cortisols, but an extremely low metabolized cortisol. That metabolism just slowing way down to meet that lower caloric intake. That set of findings is kind of easy to spot because these two gauges point right to each other. The free cortisol is on the high end and the metabolized cortisol is really low. You're like, oh, that's weird. So check out the treatment goals for hypometabolic pattern. You want to increase the metabolic rate. So check the thyroid, support thyroid hormone conversion, support the mitochondria, and support the adrenals nutritionally. Replete iron and the Bs if they're low. Low iron, for instance, in studies is associated with shortened REM phases later in the night when they should be longer. So, some of the underlying drivers of hypometabolism can affect our sleep too. And of course, the hypocortisol pattern, right, where everything's low, suggests low overall production. And when cortisol production is low, sometimes it can be due to concurrent medications or recent steroid use even. So ask the patient about what they're taking or if they've done a pred pack or a hydrocortisone injection in the last month or two. Recent steroid use can inhibit cortisol production for 4 to 6 weeks or even longer sometimes. And it can, send off alarm bells for you, but really actually just be part of the, part of the healing process from having been on steroids. That's very normal. And again, disturbed sleep in this group is real similar to the hypocortisol pattern on the slide above here. So real similar. And finally, before we move on to the acute adrenal stress cortisol pattern, I want to posit the idea that cortisol can be produced outside the watchful eye of the HPA axis. We kind of alluded to it a couple times, but we still typically think of the diurnal rhythm of cortisol being a good indicator of HPA axis function, but extra adrenal cortisol synthesis happens in the liver and the adipose, right, through that 11 beta HSD1 activity. And there's cortisol that's produced through sympathetic nervous system driven mechanisms too. So I was surprised to learn about that paracrine activity that happens from the adrenal medulla, which can release norepinephrine, epinephrine, vasopressin, even ACTH from chromaffin cells that exist there, and upregulate cortisol production kind of locally through alpha adrenergic stimulation. And remember, norepinephrine and epinephrine are fast responders to stress. Cortisol follows a little bit later and is considered the more persistent stress responder. But as fast responders, norepi and epi clearance in the liver is important. So we want to bring them out when we want, when we're dealing with a stressor, but we want to break them down, and we want them to go away and lose their influence pretty quickly once the stressor is resolved. But clearance can be slowed down in patients who are poor methylators or who have, key deficiencies in magnesium, B6, folate, those sorts of things. So, they may be anxious or depressed or sleep poorly or suffer greatly in the face of everyday stressors because they're not, getting back to baseline very quickly. So resetting the sympathetic nervous system activity after a stressor is resolved is super important and depends quite a bit on our COMT and MAO enzyme genetics and our nutritional status. And I put together just some ideas as a springboard for you to start thinking about your own protocols for approaching the patient with high sympathetic tone and sleep problems. And here's a short list of ideas for supporting parasympathetic activity in the body. You might guess what adrenal stress, acute adrenal stress looks like on the Dutch Plus, which brings us to our example here. We have a 67-year-old female patient with high blood pressure, and she has frequent and early waking, a lot of sleep fragmentation. And we do see high metabolites of cortisol there, right? And a very high morning cortisol. But look here. I think I have it all. Here we go. Here's my markup version. So we have a very high first morning cortisol, but look at that cortisone at the same time point. She really has a strong favor towards cortisol. And I just want to let you know that this is a pattern that's been looked at and is reported in the medical literature as possibly being associated with high aldosterone. So it may send you in a different treatment direction for somebody who's maybe managing their blood pressure with something that's not solving the problem for them. Maybe she needs to switch to a loop diuretic or some other approach for managing her blood pressure. Maybe she's taking licorice in an adaptogen formula and didn't realize that it was going to block this enzyme and cause her to hang on to cortisol and crank her blood pressure up even more. So these are important things to look at on a Dutch test and get a sense of, and really put it back into what the patient's coming in with to kind of figure out what it all means. Those are for you to play with, practice examples. And I just want to mention one quick thing about melatonin metabolite. On the Dutch test, melatonin metabolites are tested in urine from the first morning void, and it represents the overnight production and excretion of melatonin. So opposite to cortisol, melatonin initiates the nighttime gene expression relays, and its diurnal rhythm is really quite the opposite of cortisol's. And when cortisol is high at night, it can disrupt melatonin production to some degree in susceptible individuals. So it's really important to look at when we're looking at cortisol kind of at the same time. So I wanted to slide in a little information about supporting melatonin. We just had a fantastic talk by Deanna Minnick, who's a PhD and scientist who spoke about plant melatonin and similarities and synergism with vitamin D. You all should listen to it if you haven't already. But here are my thoughts on melatonin. We get a lot of questions on melatonin dosing and the types of dosing ranges and what the targets are with the different dosing ranges. So that's for you guys to kind of use at your leisure. Remember that melatonin is ultimately coming from serotonin production, which requires proper digestion, absorption, distribution of tryptophan to the proper tissues. Right, here's tryptophan and all the things coming off of tryptophan. Tryptophan metabolism can be hijacked right here for NAD production, and it may enter that potentially inflammatory kynurenine pathway by that same cortisol and cytokine signals that act to suppress tryptophan hydroxylase over here and limit serotonin production and downstream melatonin. So as we wrap up our talk on cortisol and sleep, I want to leave you with this slide, which is probably going to look a little bit busy, but it helps to synthesize some of the markers from the sex hormone panel and the oats panel, along with the cortisols. Feel free to use it as a springboard when you're thinking about drivers of sleep and cortisol problems that aren't responding to the usual approaches. And do feel free to utilize clinical support, and we can always walk you through what some of these markers might be telling you. I always encourage folks to read. So I included many of the references that I used to shape the presentation, and most of them are open access. Next time your adrenals have you running from the bear, I hope you'll think of our talk today. Let's find out what Dutch is offering to listeners and open it up for some Q&A.
Yeah, you guys have asked some really great questions, and we're bumping right up against our hour mark here. So what we're going to do is we're going to schedule a Instagram live with Dr. Allison Smith and one of our other clinical educators. So more information coming out on that. As a new provider, when you sign up, you can always get up to 5 Dutch Complete or Dutch Plus at a half off. So make sure you sign up today. The information to sign up is going to be in the chat. That'll lead you to our Become a Provider form. So make sure you fill that out. One of our onboarding specialists will reach out and give you that offer again, get you signed up for our Mastering Functional Hormone Testing course and our new interpretive guide. Thank you all for joining us today. Check your inboxes tomorrow for a link to the webinar recording and to download the slides. Additionally, make sure you, again, visit that Become a Provider tab at DutchTest.com and complete the steps. And don't forget to check out our summer school episodes of the Dutch podcast. New episodes will be released each week leading up to the return of the Dutch podcast, season 3 in September. Have a great rest of your day.